Hello friends, welcome back to my channel with a new video. As I said, I'm coming out with the two short videos on arrhythmia. The first one you had on bradyarrhythmia and this one on tachyarrhythmia. So without further ado, let us start with the video. So as far as the mechanism of tachyarrhythmias are concerned, it can either be due to the abnormal impulse formation, which is in turn dependent upon the automaticity, which could be either enhanced or abnormal automaticity, or it could be a triggered one where there could be either a triggered response, and there could be abnormal impulse conduction, which is mainly the re-entry kind of impulse conduction, and it could either depend upon the anisotropy, anatomical features, or the functionality. So in short, it could be either abnormal impulse formation or abnormal impulse conduction. So these are different various re-entry circuits. Either the AV nodal re-entry, which will be responsible for SVT, or ventricular re-entry causing ventricular tachycardia, or it could be atrial re-entry either causing atrial tachycardia, fibrillation or flutter, and atrioventricular re-entry causing either SVT or WPW syndrome. So in a nutshell, you can see these are the various re-entry circuits and the pathways. So tachyarrhythmia, if I have to divide, I will do it in the way where it could have either a supraventricular tachycardia, where only requires the atrial tissue or the atrial tachyarrhythmias, or AV nodal tachycardia. So atrial tachyarrhythmias are atrial fibrillation, atrial flutter, or atrial tachycardia. And the AV nodal tachycardias can either be a nodal reentrant tachycardia or accessory pathway associated tachycardia. So they could be either common or uncommon, and short CT or a long CT. So it could be either paroxysmal supraventricular tachycardias, and we'll come to one by one in a short while from now. So the ventricular tachyarrhythmias can be either the organized reentry or a disorganized reentry. As far as organized reentry are concerned, it could be non-sustained VT or a sustained ventricular tachycardia, where the patient can have sudden cardiac arrest. The disorganized reentry are in the form of either ventricular fibrillation, where the heart quirls and there is no effective cardiac output, and it could be at the rate of very high rate of 350 to even 450 beats per minute. And in torsade, you can see that the rate can be vary, and it can be between 250 to 350 beats per minute. So as we know that it is another form of ventricular fibrillation. So this is by and large the differentiating features between the various ventricular tachyarrhythmias. As I said, if you have a tachycardia, the patient comes into ER, give some oxygen, monitor the ECG, blood pressure, oximetry and capnometry. So attach a monitor, and it could be actually either of these, like a light anesthesia or hypovolemia, hypothermia or hyperthermia, early hypoxia or hypercapnia and autopip. So if you see a patient with an altered mental status or with the features of chest pain and hypotension, then of course we need to go ahead and treat this patient with synchronized cardioversion. For that, we need to take a consent, put in an IV line, and then of course follow the procedure. Before that, of course, we need to have ABCD. So you have airway, breathing for, like, look for hypoventilation, cardiac output, and the circulation, and D for drugs. So if you don't have symptoms related to tachyarrhythmia, or the symptoms which we saw in the last video, that you could either have altered mental status, you can have a hypotension, signs of shock, signs of acute heart failure, sweating, cold clammy extremities, chest pain, All these are features of the symptomatic arrhythmia, especially the symptomatic tachyarrhythmia. If the patient does not have this, then of course you can just put in a IV access, monitor the 12 lead ECG, and see how take a 12 lead ECG and see how it appears on the ECG. So as you could see, if it's a narrow QRS and if it is regular, it is probably, you are dealing with something called as a supraventricular tachycardia. So you need to have adenosine or a vehicle manure here, and adenosine, you could see the dose of 6 milligram and then 12 milligrams. If it is irregular, then you are dealing with probably like atrial fibrillation or flutter with or MAT. And in these particular patients with low LV ejection fraction or with severe hypotension, you can have amiodarone as in the dose of 150 milligrams over 10 minutes. If the patient's EF is normal, then you can consider beta blockers or calcium channel blockers. So if this narrow QRS complex regular tachycardia, if it reverts, then of course it is likely to be reentrant SVT. You need to observe for recurrence, and if there is recurrence, then you need to consider adenosine again, or longer acting AV nodal blockade agents like beta blockers or calcium channel blockers like diltiazem. If they don't convert, then of course we need to actually have the rate control with beta blocker or calcium channel blockers and reevaluate and treat the possible causes. If the ECG shows a wide QRS complex, right, a wide QRS complex, then either you are dealing with a ventricular tachycardia. In that case, amiodarone would be your drug of choice, 150 milligrams over 10 minutes, or it can be a lidocaine in the dose of 1 to 1.5 milligram per kg IV over 3 to 5 minutes, and then of course prepare for synchronized cardioversion. If it is irregular, so wide complex irregular, it could be either atrial fibrillation with aberrancy or a torsade, wherein magnesium in the dose of 2 grams IV over 5 minutes is a drug of choice. And of course, if it's a pre-excitation atrial fibrillation, you need to consider amiodarone. So this is by and large the treatment schedule for symptomatic tachyarrhythmia. So we have discussed it that this is a PSVT, irregular becomes atrial fibrillation or flutter or a MAT. Wide complex QRS regular becomes ventricular tachycardia. Wide complex irregular becomes atrial fibrillation with aberrancy or torsade, or of course ventricular fibrillation. And remember, if it's a torsade, the prolonged QT interval is the precursor for torsade and one of the responsible finding before a torsade. So this is the algorithm. You have to start with ABC, IV oxygen monitor. Here you can see that synchronized cardioversion, which is the treatment of choice. Adenosine, we have discussed the dosage. The alternative drugs in the form of either procainamide or amiodarone, which we have already discussed. These are the features of symptomatic tachyarrhythmia, and you need to synchronize cardiovert in these patients. So by and large, this is the AHA guideline, the recent one, and this is a AHA tachyarrhythmia algorithm, which we have discussed. So now let us identify this, and this is a typical PSVT. So this is a normal rhythm, and you can suddenly see that it's a narrow complex QRS and a regular one. Okay, and the P wave which is seen here, as you could see that there are P waves which are seen. So this is a classical paroxysmal supraventricular tachycardia. So it's a reentrant arrhythmia at the AV node that is spontaneous in onset. It may have neck fullness, hypotension, polyuria due to ANP. So these are features of heart failure. Narrow QRS, first line which is a vagal maneuver. Second line is adenosine, And for chronic SVT, class 1A or 1C or amiodarone, and ablation will cure it too. So we usually, which you see in the young adults. Now you can see and you can identify what is it. So you could see that the QRS complexes are narrow. This is the tachyarrhythmia, but you could see clearly that they are irregular. So here we are probably seeing a multifocal atrial tachycardia because there are different morphologies of P wave. So you could see that's a upright P wave, the biphasic P wave. Sometimes there are no P waves. So this is a typical multifocal atrial tachycardia, which is due to automatic atrial rhythm from various different foci. It is seen in hypoxia, COPD patients, atrial stretch and local metabolic imbalances. There could be three or more types of P waves morphology and a rate of more than 100. And digoxin actually worsens it. So treat with oxygen and slow calcium channel blockers like verapamil and diltiazem. So now what is it? So this is typical Wolf Parkinson White syndrome. So it's a WPW syndrome, and you could see that there are the the ventricle which receives the partial signal normally and partially through accessory pathways, and there is a very short PR interval as you could see here. So there is a short PR interval, and this is a hallmark of WPW syndrome, and a delta wave which is actually seen in a prolonged QRS. So electrophysiological testing helps to identify the re-entry pathway and location of the accessory pathway as well. Because WPW has both abnormal conduction through the AV node and accessory pathway conduction that bypasses the AV node, the atrial fibrillation can happen via the accessory pathway. Inhibition of the AV node will end up in worsening the AFib because none of the signals are slowed down by the AV node. Do not use any medications that will slow down the AV nodal conduction like digoxin or a beta blocker or adenosine, and it will make the things worse, including the calcium channel blockers. The best choice is procainamide as it slows the accessory pathway. If the patient becomes hypotensive, of course you need to cardioversion. Do the cardioversion immediately. Now you can identify this. So this is a typical flutter. You could see the flutter waves or a sawtooth appearance. So it's a very classical sawtooth appearance. So this is a atrial flutter with atrial activity of between 240 to 320. As I said, sawtooth pattern. Usually a 2 is to 1 conduction pattern. If it is a 3 is to 1 or higher, there is a AV nodal damage. Treatment is to slow down the AV node conduction with amiodarone, propafenone, and or sotalol. The DC cardioversion will help if the patient is hemodynamically unstable, and you can also ablate the re-entry pathway within the atrium between the tricuspid and the IVC. But mind you, these kind of atrial arrhythmias, especially the atrial flutters and fibrillations, they are best cardioverted within the 48 hours of onset because after the 48 hours there is a chance of the clot. So now what is it? I could see that there are narrow QRS, the heart rate is irregularly irregular, and at least I cannot identify any particular P wave pattern. So this has to be atrial fibrillation. It can be due to hypertension, cardiomyopathy, valvular heart diseases, sick sinus, WPW, thyrotoxicosis. So therapy is either rate control via slowing down the AV conduction delay or AV nodal conduction with stroke prophylaxis or rhythm control. This is a typical ventricular tachycardia, broad, complex, regular, which is the impulse which is initiated from the ventricle itself. The rate can be as high as 140 to 250. If the patient is unstable, of course, cardioversion, or if it is pulseless, then of course the cardiac arrest algorithm which will be followed with DC shock or the defibrillation as early as possible. If not, then IV amiodarone, consider procainamide, And non-sustained VT may not need treatment, but you need to obviously observe this patient very, very closely. What is this? So it's a typical, you can see that there's a spindle shaped uh, pattern, and you can see that there are kind of ribbon which are, you know, they are, it is said that they appear or they mimic uh, the inversion of the ribbon, as you could see, and the spindle shaped form complexes. So the twisting of the points is usually caused by the medications like quinidine, disopyramide, sotalol, hypokalemia or bradycardia, especially after the myocardial infarction. So prolonged QT, which is the pathognomic feature for Torsat, and in acute condition, you need to remove the offending medication, shorten the QR interval with magnesium, lidocaine, isopreterenol, or temporary overdrive pacing. In chronic patients, you may need to have pacemaker or ICDs. Amiodarone and beta blockers can also be used to mitigate this problem. What about ventricular fibrillation? There is a queering effect of the heart where you could see that it will not generate any cardiac output and the patient is in frank arrest, which is commonly seen in acute myocardial infarction. Also, drug overdosage, anesthesia, hypothermia, and electric shock, which can precipitate it. It is due to the absence of ventricular complexes and is usually a terminal event. And in patients, you need to actually have a DC cardioversion or DC, the defibrillation as early as possible to save the patient. And in the medical therapy will include amiodarone. So I think that's all for now. And this is what I wanted to discuss in this video of tachyarrhythmias. I hope you all have enjoyed. Let us meet in my next video with some new topic and with the exciting video next time. That's all for now. Bye bye. Take care.